The majority of patients with chronic myelofibrosis will have one of three mutations. About 30 to 40% will have a JAK2 mutation, and 5 to 10% will have a mutation in the thrombopoietin receptor known as MPL or MPL, and then another 40% or so will have a mutation in the calreticulin or CLR mutation. These are all part of the same pathway, and JAK2 inhibition therefore works in any patient who has a mutation not only in JAK2 but in one of these other two areas or mutations, as it's all driven through the same pathway. There are those patients, rare patients, who are triple negative. It's so rare, it's unclear how JAK inhibition helps them. But the vast majority of patients will have an effect, whether they have a JAK2 mutation or a mutation within these other genetic lesions.
In terms of the role of ruxolitinib in managing myelofibrosis patients, currently it's FDA approved in the US to treat patients who are intermediate or high risk with the IPSS or DIPSS systems. So for me, when I evaluate a patient, I make the determination of their risk group, as I mentioned before, but also look at their symptom burden and assess that very carefully, and also evaluate their spleen size. Some patients, it's very clear when you talk to them and evaluate their symptom score that they are very symptomatic from their myelofibrosis and would benefit from ruxolitinib. In some low-risk patients, this is also considered very carefully for patients who might have increased symptom burden, but according to the DIPSS score, they do not have the intermediate or high risk category of warranting ruxolitinib. But again, this is done case by case, and also we could consider using hydroxyurea to alleviate some of those symptoms as first line.
Ruxolitinib has been approved for quite some time now in the United States and Europe as a therapy for myelofibrosis. In the United States, the indication is for intermediate and high-risk myelofibrosis patients, while in Europe, in general, it's for patients with symptomatic splenomegaly or general symptoms from the disease, which in fact describes the population of the patients that benefits the most from the therapy. Ruxolitinib does not really improve the blood cell count, and we don't have evidence that it prevents progression to acute myeloid leukemia. However, from the COMFORT-1 study and COMFORT-2 study, these are two prospective long-term randomized studies that led to approval of ruxolitinib. We know that the patients live longer with a good control of signs and symptoms with ruxolitinib. And that is reflected now in a final analysis of the COMFORT-1 study, for example, which was presented 2 months ago, where patients that were initially randomized to ruxolitinib compared to patients that were randomized to placebo, and about 75% of these placebo-treated patients are randomized to nothing, basically, were eventually given ruxolitinib, and median time to crossover from placebo to ruxolitinib was about 41 weeks. So despite the crossover of 3/4 of the patients to ruxolitinib, we see significant difference in overall outcome of the patients, which is a prolongation about 3 years, about 33% longer survival of the patients that were initially randomized to ruxolitinib, confirms that with the good control of the signs and symptoms and not really elimination of the disease, we can make a huge difference. Now, this has two connotations. One is that it appears quite obvious that we should not wait for patients to be so advanced to have a less of a chance for a good response to therapy, and we should be treating patients when they really do have a symptomatic splenomegaly or systemic symptoms, and not wait for them to be in a dying process. And I think that is quite normal to accept, and we do this in normal everyday practice. We are not really postponing therapy if this is present. And the other question is whether the earlier introduction of the therapy in patients that are not symptomatic at all and don't have a big spleen would make a difference for the survival. Now, the presence of different mutations in therapy that are treated with ruxolitinib do not have real evidence to affect the outcome. First question was whether the presence of a JAK2 mutation makes a difference, and it doesn't. Patients who have a calreticulin mutation or MPL mutation or have no mutation at all or have never been tested for mutation have the same outcome, because it is not about ruxolitinib targeting any specific mutation. It targets the JAK-STAT pathway, and that is underlying problem, hyperactivity of the JAK-STAT pathway in all the patients with myelofibrosis. So one does not even need to test for any mutation, which is just a part of the diagnostic process, but not a prerequisite for introduction of the ruxolitinib. Now, we and others are looking at the reasons for some people doing better on ruxolitinib than the others. There is some suggestion that the presence of perhaps a number of other additional mutations may affect the overall outcome of the patients. That is preliminary result published only once in a limited number of patients so far. We are also interested why some patients lose the response. Is there a clonal evolution or acquisition of other mutations over time on therapy with ruxolitinib? This is all a research question, nothing really to do in everyday practice, or to monitor, for example, the number of the JAK2 mutated cells in blood and bone marrow as a test during the therapy with ruxolitinib. There is no need for that. Now, one practical point that I'd like to highlight is the clear correlation in all the studies so far with ruxolitinib between a degree of a spleen reduction and the overall survival of the patients. So my goal usually is not to be skimpy at the beginning with the dose of ruxolitinib, really to follow the guidelines and use the maximum tolerated dose, and not to, for example, worry about the anemia, which is not contraindication for use of ruxolitinib, nor anemia is affecting the overall outcome of the patients if it's therapy related, and try to shrink the spleen at the beginning as much as I can in a safe way, and everything happens in the beginning usually, for patients to benefit the therapy as long as possible, and that certainly then now we know translates in a longer survival.